Yeah, let's start.
Good evening, everyone. I'm Dr. Ashish from Medanta, third year Nephrology resident. So today I'm presenting a case of Mr. X, 58-year-old male, resident of Nepal, Hindu, teacher by profession, and known diabetic for 8 years. And he was admitted for on 14th of April 2025 with complaints of frothy urine since last 2 months and swelling over the body.
Sorry?
Frothy urine since last 2 months and swelling over the body since last 1.5 months. Informant is patient himself, and he was apparently well 2 months back when he noticed frothy urine. Initially it was small in amount of the froth that quickly dissipated. Over the subsequent week, froth became more persistent, profuse and longer lasting even after the flushing the toilet. After a week of onset of frothy urine, he noticed swelling initially appeared around the eye, more prominent in the morning time and gradually decreased as the day passes. Over the next 2 to 3 weeks, he also noticed the swelling in the lower limb, primarily around the ankle and leg, and it was bilateral. It gradually progressed to over abdomen and became generalized, and there was no aggravating or relieving factor. So for same complaint, he visited to a hospital in Nepal, and at that time he was told that he is leaking protein from the urine and his creatinine is normal and blood pressure was normal at that time, and he received some injection to increase the urine and also received one injection to increase the albumin, and he was referred for the biopsy.
So he came to you for biopsy, he told you?
Yes, sir.
Okay.
Yes, he was referred for the biopsy. No any history of cola colored urine, decrease in output, no any symptoms suggestive of orthopnea or shortness of breath, dyspnea or aggression, no history of discoloration of eye or skin, no recent history of fever, sore throat, rash, any joint pain, ulcer, no history, significant history of weight loss, decreased appetite, night sweat, bony pain, no history of any alternative medication, no history of any lump in the body, blood in stool, and patient no history of any tingling, numbness, sharp shooting pain, burning or pin or needle like sensation, no any history of lightheadedness during the standing, and no history of like bloating, constipation or diarrhea, and no history of urgency, hesitancy, incomplete voiding or involuntary leakage of urine, and no history of any decreased vision. Past history, he is known diabetic since 2017 and on oral medication, and he remember the name as metformin and glimepiride that he take twice a day, and he was on follow-up with general practitioner for the same, and he remember that his HbA1c mostly is around 6.5 to 7, and on his regular OPD visit to physician, he never got diagnosed for any high blood pressure or any other chronic illness. In the personal history, he is a non-alcoholic, non-smoker, occasional history of tobacco chewing, and consume mixed diet. In the family, patient has one sister with no known comorbidity. Patient is married with 2 daughters, and father expired at the age of 82 years with some brain hemorrhage, and mother is fine. No other any significant medical history in the family. Course of hospitalization, he was admitted on 14th April and underwent kidney biopsy, and procedure was uneventful and he was discharged.
So, coming to the evaluation of the symptoms. So, what are the positive symptoms with which he has presented, and just elaborate them towards your diagnosis, which support your diagnosis of what?
So, for this history, my syndromic diagnosis is nephrotic syndrome. The patient has a history of frothy urine, likely because of proteinuria, and he has edema. So, this is like nephrotic syndrome.
So if somebody has frothy urine and edema, so what else comes into your mind? Like you have told 2 positive findings in the history. One is frothy urine, another is swelling of the face followed by the feet and anasarca. Other thing, everything is in the negative history.
Yes, sir.
So if you are thinking of the nephrotic syndrome or any other syndrome, so what else should have been in your history in the urinary complaints or something like that to know the horizon of the disease? So you have just told me nephrotic. Why can't it be nephritic? You have nothing told in the history which can't be goes into the nephritic syndrome or some other
Yes, sir. So,
edema, the causes of edema. He may have some other liver disease or cardiac disease. So just giving there is no history of jaundice does not rule out anything else.
yes.
So just elaborate the negative history from the urinary point of view.
So, first thing, he was told that his blood pressure was normal at the time of hospitalization.
Okay.
That is, and there's no history of decreased urine output or cooler colored urine. So, this is against the mostly nephrotic syndrome.
So no, I just told you nephritic syndrome, but in the urinary findings, if you have some like frothy urine, what else like? What is cola colored urine? Where it comes? Like it is just in acute nephritic syndrome or something else also?
So,
So he is a diabetic. No? So he is diabetic from almost like 8 years, 2017. So though it is a recent onset of frothy urine or swelling of the feet, the frothy urine may be persisting for many months. He may not have noticed. When he has swelling feet, that brought him to the hospital or the evaluation for that. So even if you are saying it is nephrotic syndrome, so what is there in the history to support that? So you are saying it is etiologically what thing has led to the nephrotic syndrome? So it is a syndromic diagnosis, na?
yes, sir.
So what is the etiological diagnosis to support the cause of the nephrotic syndrome? You are saying it is diabetic or something else also?
So, I would like to keep the non-diabetic kidney disease as a first differential.
Why?
Uh, in the history, like he doesn't have any history of any history suggestive of any neuropathy or retinopathy at that time. And on the follow-up visit,
You are saying because there is no tingling sensation or anything else, so you are ruling it out autonomic neuropathy or peripheral neuropathy because of diabetes, and there is no vision loss or diminution of vision.
also
That is
he
why you are
he
saying it is not retinopathy.
yes, he also given the history that on the regular follow-up, his sugar was mostly controlled and HbA1c was around 6.2 to 7. That is on he was on regular follow-up.
So how many patients of diabetes in percentage wise, according to the literature, will have a nephrotic presentation due to diabetes in type 1 and type 2 diabetes?
Yes, sir.
So any patient who has nephrotic syndrome in who is diabetic may have a nephrotic syndrome because of diabetes or it is due to a primary glomerular disease or secondary glomerular disease. These are the three things. So when you are saying it is nephrotic syndrome, we have to keep diabetes because he is diabetic. Okay, but you are saying your first diagnosis is other glomerular disease rather than diabetes. So I am saying according to the literature in type 1 or type 2 diabetes, what is the incidence of nephrotic syndrome as such and other glomerular diseases?
So, in diabetic patient, around 20 to 40% patient can have other disease apart from.
Yeah. So in what is the incidence in type 1? So probably he is 50 years old, he is not type 1 diabetes obviously. So he is type 2 diabetes. So how many percent of the patient like of 50 years of age with nephrotic range proteinuria will have diabetic nephropathy per se? I'm not asking about this patient particularly.
So, it's around 40%,
It is more.
more 40 to 50%.
Yeah, more than 50 to 60% will have nephrotic range proteinuria because of the diabetes, and rest 30 to 40% will have other disease. So in diabetic patient with the nephrotic range proteinuria or diabetic nephropathy, so you will have to see the overall chronology. So if he is having 7 to 8 years of proteinuria diabetes mellitus, and now he is presenting with nephrotic range proteinuria or nephrotic syndrome. So you will have three things coming into the mind. One is diabetes per se causing nephrotic syndrome, other is primary glomerular diseases coming, and other is systemic diseases. So in this you are saying your first is non-diabetic glomerular diseases. In non-diabetic, what is like your primary is primary glomerular diseases or secondary glomerular diseases?
Uh, so as a primary glomerular disease, although diabetic kidney disease can be in a background, like
Yeah, that can happen. So among the primary glomerular diseases, what diseases comes into your mind in this patient?
considering his age and this basically onset, that is a more of gradual onset. First, I would like to keep membranous as a first differential,
Okay.
and then other primary glomerulopathology like FSGS and adult onset minimal change disease, that can, the incidence is less. But
Any other secondary glomerular diseases which comes into your mind at this age group?
at this age group, I would like to keep the differential of like myeloma spectrum disorder or
Sorry?
myeloma spectrum disorder or amyloid.
Amyloid.
Yeah.
Okay. So is there anything?
But
So in your history, anything which supports your diagnosis of membranous?
uh, uh, that basically this onset, that is more on gradual, because if other like
It is not gradual. It is like just 2 months of history. It is not more than 3 months or 6 months. So you will not say it will be gradual onset or something. It is a very rapid onset. Like he was asymptomatic 2 months back, then he has frothy urine or something like that, and then edema. So there is anything in the history which supports your diagnosis of membranous as a first. So at this stage, you can say that I need further evaluation in the form of urine examination or something like that to support my diagnosis.
yes, sir.
Okay, and what are the basically the causes like for frothy urine? So one is the proteinuria. Any other thing which comes into your mind? Any other differential diagnosis for frothy urine? Any other abnormal pigment which can cause?
The rhabdomyolysis, but
That is again myoglobin. So there are certain, not in this case, but certain genetic diseases, okay, in which there is again a color change also along with the proteinuria. So they should also be considered in frothy urine. So you said in the hospital, during his hospital admissions, he was given some injections and some diuretics and albumin. After that, he responded or what?
he responded. Yes.
He responded. So when he came, his edema and everything, according to him, was less or
Yeah,
what?
it was very mild, but just to the
Very
ankle.
less. And then any other disease in the systemic causes which comes into your mind? One you said amyloidosis, other is any other? Though he is a male, any other secondary glomerular diseases?
Like lupus.
Lupus.
As male.
But anything positive in the history regarding that?
No, sir. There's nothing extra renal manifestation.
There is no extra, no joint pains, nothing, no ulcers or anything like that. Okay. So your syndromic diagnosis is nephrotic syndrome. Anything else comes into your mind? Diabetic kidney disease. So in a patient who is diabetic, so what are if I say he is having some diabetic kidney disease? So what spectrum do you think comes into your mind of diabetic kidney diseases? Previously we used to say diabetic nephropathy. Then the term came diabetic kidney disease. Now we say diabetes with CKD. So do you understand the difference between all these three terms?
So, uh, so diabetic kidney disease basically has 4 trajectories different.
So diabetic nephropathy was the original term when there was it was established during description of type 1 diabetes. So when you have albuminuria in CP and nephropathy, overt nephropathy with proteinuria, so once the patient has established overt proteinuria, it was used to be known as overt nephropathy along with the presence of retinopathy. So that was in type 1 diabetes. Then the term came diabetic kidney disease. When the GFR, the classification of CKD 1, 2, 3, 4, 5 came. So in that scenario, when there is decrease in the GFR, so the diabetic kidney disease was term. And now diabetes with CKD, because the spectrum is growing. There are many things which are happening in diabetes also. And many of the times the biopsies is not done. When there is a established diabetes of long duration, retinopathy, so obviously you don't do the biopsies. So because when you are not sure, so you say diabetes with CKD. Okay, so you have now nephrotic syndrome. So how will you proceed with the physical examination in this case?
So in the general examination, patient was alert, conscious, cooperative, sitting on the bed comfortably. BMI is 22, no pallor, icterus, sinuses clubbing or palpable lymphadenopathy. Edema present till ankle, pulse was 86 per minute, regular rhythm, good volume, felt in all 4 limbs. Condition of vessel wall was normal. Blood pressure was 126/78 mm of Hg on right arm supine position and 120/70 on standing. There was no significant postural drop. Respiratory rate was 18 breath per minute, abdominal thoracic, adequate hydration. There is no any sign of skin pigmentation, hair, nose, throat. Oral cavity was normal, no any periorbital puffiness, no gentle asthmas. Neck, no swelling or any bulge. Chest, abdomen, back and genitals were normal. In the leg, there was no callus deformity, any hyperpigmentation for the leg.
So there is no positive finding.
No, sir, except edema till ankle. That's it.
Anything else you are looking for?
Then I'll do the fundus examination. So in the fundus examination, there is no signs of retinopathy.
So what are looking for in the fundus?
So fundus examination, I was looking for any microaneurysm, any.
What are the broad categories like you see in the diabetic?
So non-proliferative diabetic retinopathy and proliferative diabetic retinopathy.
So what is the hallmark of non-proliferative?
Sorry, sir.
What is the hallmark of non-proliferative diabetic retinopathy?
There's a microaneurysm.
Mm-hmm.
Okay. There's venous bleeding, intraretinal microvascular abnormalities.
Mm-hmm.
Then dot and blot hemorrhage.
Dot and blot hemorrhages.
Yes, sir.
Mm-hmm.
And soft exudates.
And proliferative?
In the proliferative, there's a neovascularization at the disc or the elsewhere. There's a pre-retinal hemorrhages. There's a macular edema.
Yes.
Retinal detachment. Yes, sir.
Yeah, in the so this patient doesn't have any.
No, sir.
So it was done by you or ophthalmologist?
Sir, I did it and then confirmed by the ophthalmologist again.
So there was no dot blot hemorrhages, nothing, no evidence of.
No, sir.
So totally negative finding. So
Yes,
he
sir.
has no retinopathy. So okay. So he has just edema. Blood pressures were okay. No retinopathy. So now, what is your diagnosis?
Urine examination.
Urine.
It was pale yellow, no foul smelling. In the dipstick, protein was 4 plus, glucose blood was negative, and in the microscopy, no RBCs, WBCs.
So bland.
Yes, sir.
Straightforward case हो गया तुम्हारा. Anything else? Just urine protein 4 plus.
Yes, sir.
So you have done with the dipstick.
Yes, sir.
And microscopic, no RBCs, no WBCs, no cast. And no frothiness of the urine. No. So how will you check the proteinuria?
With the dipstick, sir.
Yeah, so what is the procedure? What is The grading you said, no, 4 plus.
Yes, sir.
So what is the color change?
So, for the dipstick, I basically took a urinary container and then dip for the 1 to 2 seconds and then read it at 1 minute in the horizontal swing. So it changed into a blue color basically.
So what does 4 plus indicate?
More than 1 gram proteinuria is there.
So what is the grading on dipstick?
This, this trace basically negative less than 15.
Negative, yeah.
Less than 15 mg, and then trace 50 to 30, and for 1 plus 30 to 100, 2 plus 100 to 300, and 3 plus 300 to 1 gram, and 4 plus more than 1 gram.
More than 1 gram. So any other method to see the protein in the urine?
Bedside or sir, on the lab?
On the lab.
So in the lab, we do it by 4 methods. Proteinuria. First, the biuret method. In the biuret method, basically we quantify the peptide bond with the help of the copper. Second method is turbidimetric method that we commonly use. So in this we use sulfosalicylic acid or triacetic acid, and with the densitometer we calculate the amount of protein. Third is dye binding method, and last is nephrometric method. So nephrometric method we use the anti-albumin antibodies with color coding.
So the commonly used is the sulfosalicylic acid method.
Yes sir. So,
yeah. So how will you do it?
Sorry sir.
कैसे करते हैं? How in the lab it is done?
In the lab, basically we take 3 part of sulfosalic acid and 1 part of the urine, and then.
So how much urine, how much sulfosalicylic acid? One part तो कुछ भी नहीं, test tube है. So basically around 2 ml of urine, 8 to 10 drops, and 8 ml of sulfosalicylic acid. So what will you observe?
Precipitations.
So when you mix that, so how will you? It is also like graded, na?
Yes sir.
Negative, trace, 1 plus, 2 plus,
Yeah.
4 plus, उसमें भी आते हैं. So obviously you don't do it clinically, you check it dipstick, but some examiners do ask these methods in the exams because they have done in their times, so they know it very well. So there is a flocculation basically. So 4 plus is all the white flocculation with the turbidity with the palate. So that is the 4 plus. But initially negative is negative, then there is a flocculation, then opacity increases. So it is a grading.
Yes,
So you will have, then there is a black ring appearing at the bottom, separating the supernatant and the flocculant. So that is 4 plus. So you can see that. So that protein estimation is usually asked in these such cases during the examination. Then how will you check for the glucose?
For the glucose.
Dipstick हो गया एक तो.
Yes,
Otherwise?
Otherwise, we use Benedict solution. So we use the orthotolidine basically as a.
इसमें जो प्रोटीन के लिए होता है डिप्स्टिक में क्या यूज़ करते हैं? What is the name of the dye?
Tetrabromophenol.
Tetrabromophenol, yes. Okay. So what other things you check in the urine routine?
Yes.
Apart from the color,
Yes, sir.
protein, glucose, what else?
pH, specific gravity, leukocyte stage, nitrite.
What is the normal pH?
Normal pH is between 6 to 8.
Usually 4.5, 5 to 8. Usually acidic, na?
Yes, sir.
Yeah. Then specific gravity?
Normal specific gravity is 1.005 to 1.030. Specific gravity.
So what happens in cases of nephrotic syndrome or chronic kidney disease?
In case of nephrotic syndrome, because there is a proteinuria, so every 1 gram of albumin, there is an increase of specific gravity of 0.001. And in case of CKD, because there's a loss of tubular function, so mostly they will present like isocystinuria.
Yes.
There is no concentrating or
Yes.
dilating property.
Yeah. So you said like the urine color was yellow. What other colors you know of, abnormal colors in the urine?
Sir, green color urine. So green color urine can be in Hartnup disease.
In the?
Hartnup disease.
Okay.
And there's some drugs that causes the green color urine. That is promethazine, trimethoprim, promethazine, trimethoprim, and
Triamterene, I don't know.
methylene
ग्रीन कलर के लिए सबसे इम्पोर्टेंट कौन सी ड्रग होती है? मिथिलीन ब्लू.
Sorry?
Methylene blue.
Methylene blue, yes sir.
Yeah, methylene blue. Where methylene blue is used? Which conditions?
Carbon monoxide poisoning. And
ICU में कहाँ पे यूज करते हैं? Anybody?
and sodium nitroxide
Resistant shock.
resistance shock.
CCU में यूज होती है ना. So before green color, what other common colors? Red color.
Red color, porphyria.
सबसे पहले क्या दिमाग में आता है? Red color. Hematuria.
Hematuria. Yes,
So hematuria क्या? So whether it is a hematuria or hemoglobinuria or myoglobinuria, how will you differentiate?
So first we'll do dipstick. If dipstick negative, so it's likely if dipstick is negative, because it detect for RBCs hemoglobin, myoglobin. So cola colored urine with dipstick, so either it is porphyria or some basically
First common things. So hematuria is basically RBCs in the urine. Hemoglobinuria and myoglobinuria are when the RBCs have ruptured. So hemoglobin has been released. So सबसे पहले you just keep the urine sample. So if the RBCs settle, the supernatant becomes clear, and the niche becomes red. So it is probably hematuria. It is not hemoglobinuria or myoglobinuria. Okay, and then you can differentiate on the microscopic. So if you think it is a hemoglobinuria or myoglobinuria, so what are the tests done?
So after basically centrifugation, if the supernatant is clear, so likely it's RBC rule out. Then if the supernatant is high colored, then we'll allow it to for 4 to 6 hours. If it get clear, then it is likely hemoglobin. And if the high colored urine persists, then myoglobinuria. And then we can do ammonium sulfate test. With the ammonium sulfate, this myoglobin basically dissolved with the 80% and hemoglobin to 100% of ammonium sulfate saturation.
So to detect these, how you collect the urine sample? So in how much time, or it has to be like examined within how many minutes, or
ideally
to have the
Yes, sir.
okay results? Otherwise, the results will be fallacious.
So ideally, it should be examined within the 1 hour. Ideal situation.
Ideal is half an hour.
Half an hour, yes, sir.
So if there is delay, so what you do?
We can refrigerate it and
Refrigerate
at the 4 to 8 degrees centigrade. Yes, sir.
8 degrees.
4 to 8, yeah.
Yeah. If you do below that, and then once you have refrigerated it at 8, and then you want to examine it, so you will have to rewarm it at room temperature. Don't do before that. It has to come to the room temperature. Okay. So what other colors? One is yellow colored, red colored, green colored.
Then orange color can be because of rifampicin, pyridium, and carotene.
Yes.
And
Purple color.
purple because
Purple urine bag syndrome you must have.
In the UTI, especially like Proteus and Pseudomonas.
Proteus, E. coli, Klebsiella. The patients who are on Foley's catheter for many days, constipated and bedridden, they may have like this purple color. Sometimes methylene blue also, green also deti hai, it may have. Hello sir. So एक बार थोड़ा समराइज हिस्ट्री समराइज कर दो बस.
My patient is a 58-year-old male, long-standing, well-controlled diabetic with frothy urine and swelling of the body since last 2 months. Sir. With syndromic diagnosis of nephrotic syndrome.
Swelling since 2 months?
Yes, sir.
You are summarizing, na?
Yes, sir.
कुछ थोड़ा सा बता दो ना कि है ब्लड प्रेशर कितना है उसका, पैदर है या नहीं है.
Yes, sir. Okay.
So just summarize.
हाँ, summarize means summary, ना?
So, this 58.
Exam also चाहिए.
नहीं.
Exam also examiner wants to be summarize the test. तो उसमें summarize करने के लिए you should know how to summarize, ना?
So that will give you a crisp information.
58-year-old male, long-standing, well-controlled diabetes with frothy urine and swelling of the body, with normal blood pressure and
Of 2 months duration. Duration is important.
With normal blood pressure and normal systemic examination finding.
इसमें you should say that there is no evidence of retinopathy. So that is important to know whether it is a diabetes related disease or some non-diabetic disease you are talking about.
और हिस्ट्री में इतना बता दो कि there is no evidence of any coronary artery disease.
No, sir.
BP कितना है?
BP sir इनका 124/70.
Without any antihypertensive.
Yes, sir. No, not
Okay, so you said that it is a nephrotic syndrome.
Yes, sir.
Why do you say it is nephrotic syndrome?
This on the pistic, the proteinuria was 4+. So
You have done yourself?
yes, sir. So with the proteinuria of nephrotic proteinuria with the patient having edema, nephrotic syndrome.
Suppose if you don't have dip states, how will you do test urine?
Then we can do bedside urine test with heat coagulation or with the use of sulfosalic acid.
What is the procedure? How will you do?
For the this heat coagulation test, we'll basically take a urine in the test tube and we'll heat the upper part of the urine and then we'll wait. So if there is a basically sediments or flocculation, then it's like proteinuria. And
No,
The part you are heating,
yes, sir.
not the sediments, the
Upper
part you are heating.
Yeah, upper part of the urine is.
So what happens to that?
what happened to that? Is it always that you have precipitation?
No, sir.
so
basically
बताओ ना क्या क्या होता
if
है?
there's a proteinuria more than 1 gram, like so it will be precipitate. Otherwise, there will be turbidity or cloudy urine. In that case, if the proteinuria is like less than 1 gram,
So that turbidity can be due to something else also.
yes, it can be because of phosphate.
Okay.
So what you do that?
In that case, we'll add the sulfosalic acid, and that phosphate will precipitate with the acid.
Now, what are the causes of frothyuria?
एक तो बता ही दो जो तुमने बताया.
Proteinuria is a.
Why there should be froth in protein?
So protein decrease the surface tension. Mostly whenever we urinate, there is some froth, but it usually dissipated because mostly flush off. But when there is a high albumin, and this decrease the surface tension and basically stabilize the bubble. That's why there's a froth urine.
What are the other causes of frothyuria? One you said is proteinuria. Anybody? What are the other causes of frothyuria?
Full bladder, forceful voiding, and other detergents present. And
That is fallacious.
So why do you say it is nephrotic syndrome? What is the definition of nephrotic syndrome?
So nephrotic syndrome is defined as a proteinuria more than 3.5 gram with hypolipidemia or edema.
अब क्या है डेफिनेशन? 3.5 है या 3 है?
So 3.5 gram of proteinuria 24 hour or UPCI more than 3 gram.
or
with hypolipidemia or edema.
So we were discussing his urinary examination findings. So he has told about the various colors of the different urine and about proteinuria. And
what is the normal क्या होता है? How much is the normal protein in the urine?
Normal protein is less than 150 gram per day.
In 24 hours.
Yes, sir, per day.
So what is the main constituent of this?
Sir, around 20 to 30% is albumin, remaining time phosphate protein, IgA, retinol binding protein.
What is the new name for TAM phosphoprotein now?
Neuromodeling.
तुम्हें नहीं पता?
Neuromodeling, sir.
और कई कुछ होता है, लाइसोजाइम्स होते हैं, इम्यूनोग्लोबुलिन्स होते हैं, नहीं?
Yes, sir.
तो अच्छा प्रोटीन यूरिया डिस्कस कर रहे थे, चलो बताओ फिर.
so now this patient has 4 plus proteinuria. So in nephrotic syndrome, like you said, like proteinuria. So what are the other constituents like having of nephrotic syndrome? One is hypoalbuminemia, edema. What else?
Previously, dyslipidemia and
Dyslipidemia and lipiduria.
lipidemia.
So what will you find in the urine examination for that? You can have some findings of lipiduria.
Fat
So I will.
levels can be-
Yeah. So in the microscopic examination, what will you find?
the lipid globules can be there in microscopy. Lipiduria.
So some specific things are seen in the urine if there is lipiduria.
Fat,
Fat globules.
fat.
What else? There is something specific for this. That is why I am asking. Something you see in the polarizing light.
Cross, Maltose cross appearance.
Maltese cross.
Maltose cross appearance.
What other things? So you said there is no RBCs, no WBCs. Okay. So you had seen yourself microscopic examination.
Yes, sir.
How had you done it?
Sorry, sir.
कैसे किया था? How you have processed the urine for microscopic examination?
So I took a 10 ml of urine and then centrifuged it for basically 2000 RPM for 10 minutes, and then the
10 minutes.
Then 9.5 ml of supernatant was basically removed, and 0.5 ml was used for the microscope.
Normally centrifugal, how at what speed and what
So
for how much duration?
2000 RPM.
क्यों भी बताओ कुछ? Anybody knows? 10 minutes तो नहीं होता.
It is like 1500 RPM at for 5 minutes, which is standard.
Yes. और तो 3000 करना है तो 3000 is for 1 minute. Otherwise 1500 for maybe 3 to 5 minutes.
Otherwise, your cast and everything will be
Destroyed.
Okay, so this is the standard thing. So you have taken the pallet and then
With the pipette, I'll take the remaining 0.5 ml, and with the cover slip, we'll check this microscopy. 160 and 400.
so how will you differentiate between the WBC and RBCs on microscopic examination?
RBCs are basically round oval shaped with central pallor. WCs have mostly granules within the cytoplasm.
Yeah. Okay. And how will you see the what else can you find in the microscopic examinations? So in this case, you said no RBCs, no WBCs. So if I say there are some RBC cast, so how does that look and what does that mean?
That signifies the glomerular, basically hematuria.
Glomerular,
Hematuria.
okay.
Presence of
So it is a sign of some glomerular
injury.
proliferative injury. So glomerular nephritis. So nephrotic syndrome, nephritic syndrome. So difference comes in the no RBCs, RBCs cast. Okay. So what else? What else you can? One is RBC cast, WBC. What else you can find in the microscope?
Crystals.
Any other types of cast?
Broadcast or
Broadcast is
WBC
seen in
cast.
which cases?
In the ESRD.
Chronic kidney disease.
Chronic kidney disease.
Okay. Muddy brown granular cast in which condition?
In tubular necrosis, ATN.
ATN, yes.
Yes, sir. Then we can get WBC cast in case of UTI.
Pyelonephritis.
Pyelonephritis.
Okay. Okay.
What is the differential diagnosis?
Sir, I keep the differential diagnosis as a non-diabetic kidney disease as the first differential, being membranous as the first differential among them.
So you are saying you are telling the causes of
Nephrotic
syndrome. Sir is asking, apart from nephrotic syndrome, any other diagnosis comes into your mind with frothy urine and swelling? Can it be just a diabetic kidney disease with chronic CKD?
Yes, sir. It can be.
So any diabetic patient with chronic kidney disease can present with the swelling feet and edema and proteinuria. So they can also have.
Mostly at the.
But you have kept your first diagnosis at nephrotic syndrome because of the non-diabetic kidney disease. So what are the points in favor?
Mostly patient at the time patient developed this overproteinuria. Mostly they have some hypertension as an natural history.
So patient is non-hypertensive. One you just want to say.
Then the onset is very rapid. Like in 2 months, he developed this much of nephrotic syndrome-like presentation.
Okay. Third important thing in the physical examination.
Absence of retinopathy.
Yes. So that is important finding. So these three things, usually the diabetic nephropathy or diabetic kidney disease (CKD) is usually associated with the rise in the blood pressures also,
Yes,
hypertension.
Yes.
Okay, and if it is a long-standing of 8 to 10 years duration with leading to proteinuria, probably because of the uncontrolled diabetes, will have some retinopathy. It is not always, but almost like 60% of the patients will have retinopathy. 40% may not have the typical in type 2 diabetes. But in type 1, 80% will have retinopathy, 1/3 will not have. Okay, so that is the thing. So anything else you want to tell in urinary examination to support your diagnosis? So coming back to your diagnosis, what are
the possibilities he has kept?
Here,
Non-diabetic kidney disease,
Yes, sir.
and possibilities?
Membranous nephropathy, FSGS, and adult onset MCD.
So why FSGS first and MCD second?
Considering his age, the basically incidence of adult onset MCD is less in comparison to this FSGS.
Anything urinary finding which is not supporting your diagnosis of FSGS?
Mostly these patients has this lipiduria
And RBCs
and RBCs, yes.
in the urine.
Can it be IgA nephropathy?
Yes, sir, it could be, but the IgA nephropathy presenting like nephrotic syndrome is less than 5%, but it can. But again, there's an absence of RBCs, hematuria. So,
Any other 58-year-old presented with nephrotic syndrome? Any other condition?
sir, at his age, this age, I would also like to rule out this myeloma spectrum disorder or amyloid.
Again, we should suspect whenever there is a patient of around 50, 60-year-old male.
Yes, sir.
From multiple myeloma or paraproteinemia.
Yes, sir.
So what will you find in the urine examination in a patient with paraproteinemia or myeloma related disease? So dipstick is basically for albumin.
Yes, sir.
So if there is light chain,
So,
whether it will be detected
in, so I'd get the in the urine examination in the conventional method basically I'll get proteinuria, but dipstick will be mostly negative or
so when there is dipstick negative, but in the conventional sulfosalicylic you find the proteinuria. So if there is mismatch, you can suspect that.
non-albanic proteinuria is there.
So this is because.
Because there is non-albanic proteinuria in the.
So what kind of proteins they are known as? Benz-Jones proteinuria.
Yes,
So how will you detect in the
How will
urine
you
exam?
test for Benz-Jones protein?
With the heating, basically at the 50 degrees centigrade, these get dissolved and then again reappear on the cooling. BC protein.
So
At
first,
what temperature you will have precipitation?
At the 50 degrees centigrade.
Then what will happen when you will
further reheat it.
heat it?
Then dissolve at the 100 degrees centigrade, these again get dissolved.
At what temperature?
At the 100 degrees centigrade.
It is not cooling, it is you heat and then further heat, then they disappear.
Disappear at the 80 degrees centigrade.
Okay.
What is the natural history of diabetes? Diabetic nephropathy.
In the natural history, patient usually, basically in the initial stage, there will be hyperfiltration in the initial 3 to 3 years, and then patient develop the
पहले तो नेचुरल हिस्ट्री ऑफ डायबिटीज़ बताओ. जब नेचुरल हिस्ट्री बतानी है तो पहले बताओ टाइप 1 और टाइप 2.
Yes, sir. So
तो टाइप 1 की क्या हिस्ट्री है, टाइप 2 की क्या हिस्ट्री है?
Natural history is usually of type 1, which is like standard.
So in the type 1, there's a hyperfiltration in the kidney, but there will be no hypertension, there will be no renal dysfunction, there will be no proteinuria, and then in the 5 to 10 year, patient basically develop the intermittent proteinuria, that is exercise induced, but at this time there was no hypertension or renal dysfunction. Over 10 to 15 year, patient developed this moderately increased proteinuria, fixed proteinuria, with the absence of nocturnal dipping at this time, basically, and no renal dysfunction. In 15 to 20 year, patient developed this severely increased proteinuria with hypertension and renal dysfunction.
So you are saying in 20 years, patient develops overt nephropathy or severely.
It's in 15 to year 2. Yes, sir.
So in the natural history, like first 10 years, then 5 years.
Initially it was 2 to 3 year first stage.
Hyperfiltration injury, that is
in the
okay.
initial 2 to 3 year, then
Yeah.
next 5 year patient developed this intermittent proteinuria,
Yeah.
and next 5 year patient developed the moderate increased proteinuria, and next 5 year likely
Yeah.
severe
So
increased proteinuria.
previously it was called incipient nephropathy and overt
overt
nephropathy.
nephropathy.
Now after the KDIGO classification, it is known as moderately,
Moderately, severely
severe and
increased.
severely, A2 and A3.
Yes, sir.
Okay, so that A3 category comes after 15 years or 20 years. So if a type 1 diabetes has not developed any proteinuria after 20 years of diagnosis, whether he is going to develop nephropathy after 20 years or not, what are the chances? So one patient who is diagnosed as type 1 diabetes at the age of 10 years, okay, and next you have followed him 20 years, 30 years. At the 30 years of age, he has not developed any proteinuria. He is well controlled diabetes and everything. So whether after 30 years he is going to develop nephropathy, what are the chances?
Sir, so there are some around in diabetes, type 1 diabetes, around 20% cases can have non-albuminic proteinuria, non-albuminic kidney, basically non-proteinuric kidney disease.
I'm not asking about the kidney disease. I'm just asking albuminuria. 20 साल तक he has not developed. Because of his controlled diabetes. So what are the chances he will develop after 20 years? Is there any studies regarding that? So the chances becomes very less. It is like 3% per decade. The
Yes,
chances
sir.
of developing nephropathy. So this is something related to genetic susceptibility. So these are the subset of the patients who are not predisposed. So genetic susceptibility also plays a role in the nephropathy progression. Okay. Yeah.
Type 2?
So in type 2, there's a complex interplay between like dyslipidemia, hypertension, proteinuria. So this doesn't follow that natural course we already defined in the type 1.
So how many percentage of the patients are having diabetic nephropathy at presentation in type 2 diabetes mellitus? So once
So
the
the chances is around 40 to 50% in
at presentation, I am saying. So if the patient is diagnosed at type 2 diabetes at the age of 40, 45, so what are the chances he is having diabetic nephropathy or proteinuria or albuminuria at presentation?
20% to 25%.
8 to 10%.
8%.
To 10%. So then it increases because of the interaction between the blood pressure control, diabetes control, genetic susceptibility, other things, infections and all those things.
What are the non-diabetic, this incidence of non-diabetic kidney disease in diabetes, and what are the Indian studies you know?
So it's around 30 to 40% patient with diabetes can have non-diabetic kidney disease.
1/3.
1/3 around.
Any Indian study? After you in exam, you are supposed to give some reference for this. Na? Batao bhai? Huh? 49%. No, reference. Bhai, all of you should read that study, because that study has examiner is going to ask you, and incidence is very high. That was from SGPJ Lucknow.
So what are the non-diabetic kidney diseases? What are the common non-diabetic kidney diseases apart from the nephropathy, proteinuric nephropathy? So that subset includes what kind of diseases?
So IgA nephropathy is most common among
IgA nephropathy.
IgA nephropathy.
Okay.
Then that is around 15%,
No.
10 to 15%, and then
ज़्यादा बता रहे हो, high. It's not that high IgA. So apart from one is the primary glomerular diseases, which are in general population. Diabetic patient can also have, like you are saying in this patient. You are saying the membranous हो सकती है, MCD हो सकती है, FSG हो सकती है. So this is like any general population patient which can have at the age of 50 years of age. So diabetic patient per se, because of the diabetes, what else can have in the kidney? So diabetic patients are more prone for infections.
yes, sir.
So if they have repeated infection, pyelonephritis, what kind of disease they will have?
Because of this FSGS.
नहीं भैया.
Pyelonephritis.
Yes, sir.
So you see, any patient of pyelonephritis admitted in the ward, like 60 to 70% are diabetic. You agree? You are seeing every day. So when they have pyelonephritis, healing, chronic pyelonephritis repeated, so they will have CKD, CIN, tubulointerstitial like presentation and progression. So chronic pyelonephritis in diabetics is common. Other thing, diabetics are more prone for atherosclerotic disease.
So ischemic kidney
Every
disease.
component B, glomerulus B, artery B,
तो they will have
tubules B,
atherosclerotic
interstitium B.
disease, तो वो होगा. तो renal artery stenosis, ischemic nephropathy, that is there. Okay. Then any other disease like you are saying glomerular disease, it follows the same general population. So like if in this 50 years you have kept membranous because of the age. Otherwise, if I want to ask you, what is the incidence of FSGS, membranous or MCD in a general population, non-diabetic general population? What is the incidence in the present scenario, Indian scenario? What is the latest study published from AIMS like 4 or 5 years back?
So in the children, this is
Children MCD, there is no doubt. Adults,
in the
50-year male, non-diabetic. What are the incidence of membranous, FSGS, MCD? These are the three main of nephrotic syndrome. So what the Indian study from the AIMS published 4 years back says. So it is almost like they have compared like 3,000 biopsies of the nephrotic syndrome, and in that they found like 22% were like membranous, and then 20% were like FSGS, and then 18 to 15 to 18 were MCD, and then other subsets, IgA and all those things. So membranous comes first. But if we see the Western data, so in that FSGS is the first one, then membranous, then MCD in this age group. So these figures, at least in Indian context, you should know.
What is the pathogenesis of diabetic nephropathy?
So in the pathogenesis, so there's a basically hyperglycemia. There's a formation of amyloid product, then advanced glycosylation product. So advanced glycosylation products basically cause afferent arterial dilatation, and this afferent arterial dilatation mostly cause intraglomerular hypertension. But here glomerular feedback is lost because there's a glucose and sodium loss. So this TGF is basically lost. That's why there's intraglomerular hypertension in this case. And once there's an intraglomerular hypertension, there's a protein leakage. There's a stretching of mesangial. There's a basically podocyte injury that releases angiotensin 2.
What happens? You said na afferent dilatation. What happens to efferent?
There's a basically high angiotensin 2. In this case, that causes the efferent arterial constriction. So that basically causes intraglomerular hypertension. The main issue here.
How the proteinuria occurs?
So proteinuria occur because first there's an intraglomerular hypertension that per se causes the leakage of protein. Second, there's a podocyte injury. So there's a podocyte injury because of this intraglomerular hypertension. Angiotensin 2 causes increased apoptosis of podocytes, and this angiotensin 2 again causes this decreased expression of nephrin, neurophilin, and this affect the barrier. And there is a basically mesangial stretching, mesangial hypercellularity will be there.
That is the biopsy finding.
Yes, sir.
So if you do the biopsy of such patient, what are the findings? Diabetic nephropathy?
So there will be basically glomerular capillary GVM thickening will be there. There will be mesangial expansion. There can be arterial hyalinosis sclerosis, different. There's nodular sclerosis can be there, and in the ESRD there will be IFTA. So
Glomerular sclerosis.
yes, glomerular sclerosis.
So what are the name of nodular glomerular sclerosis?
Kimstein-Wilson lesion, KW lesion.
So where you find, what are the other causes of nodular glomerular sclerosis?
Smoking is, smoking is.
Smoking?
Yes, sir.
Smoking causes which glomerular disease?
This nodular sclerosis can be seen in smoking.
Smoking causes Kimmelstein-Wilson.
No.
So that is the typical for diabetic nephropathy. The name is given to, because nodular glomerular sclerosis is a histological finding.
Yes, sir.
So this kind of appearance can appear in other glomerular diseases.
What are other diseases?
What are the other diseases which can cause nodular glomerular sclerosis? आपका biopsy में भी DD होंगे ना?
Yes, sir.
तो क्या होते हैं?
So amyloidosis.
Amyloidosis, okay.
Then
Important.
LCDT, light chain deposition disease.
वो amyloid का part हो गया, light chain deposition. Fibrillary and immunotoxide glomerulopathies. So how will you differentiate whether it is because of these or because of amyloid or because of diabetes?
So in basically in amyloid there will be deposition of this
So your answer comes, light microscopy के बाद क्या करते हैं? IF?
IF. Yes.
तो IF में क्या मिलेगा? डायबिटिक नेफ्रोपैथी में IF में क्या मिलेगा? IgG, IgM, IgA, C3, C1q यही करते हैं ना?
Yes, sir.
बट डायबिटिक नेफ्रोपैथी में क्या मिलेगा? विच स्टेनिंग? Albumin. Okay, because albumin is leaking from there, so albumin is there in the glomerular capillaries. तो albumin staining मिलेगी. Amyloid में क्या मिलेगा?
So the Congo red appearance मिलेगा apple bisphenium in the
Congruent appearance मिलेगा.
apple bisphenium Congo red पे apple bisphenium staining मिलेगी इसमें amorphous material की.
Amorphous material मिलेगा और अब amyloid उसमें तो आपने staining कर ली. अब now how will you differentiate between amyloid and fibrillary and immunotactoid?
So that kind of
अब
difference in the electron microscopy,
Yes.
the arrangement of the fibrils.
So the fibril size is different
Size and
between the fibrillary, immunotactoid and the amyloid. Then amyloid is also of how many types?
Primary and secondary.
So what are the components amyloid के?
Like
AL and
primary
AA.
AL amyloidosis, primary and secondary the SA amyloid or ATTR beta 2 microglobulin.
So in your nephrotic syndrome, when you have kept like primary glomerular disease, is there any possibility of secondary glomerular diseases in the form of amyloid or lupus or myeloma in this patient?
So,
Is there any possibility of SLE?
Yes, but
How?
but
What are the points in favor of SLE? Any one point? How SLE presents? He doesn't have any history of joint pains, rash. He's a male, 50 years, which is against it. In urine, there is no activity, no RBCs, nothing. His blood pressure is controlled. So, there is nothing in the history or the examination to support a diagnosis of SLE. Is there any possibility of myeloma?
this is nothing. Only considering age, but no history and examination findings history of any myeloma because.
So nephrotic syndrome is a, but one age can have any other thing? No.
No, nothing. Sir.
Amyloid?
For the
Again, AL because myeloma related nothing, and any chronic illness, he doesn't
No,
have
no.
any rheumatoid arthritis, ankylosing bronchiectasis, any history of tuberculosis, any other chronic illness. He doesn't have anything bronchiectasis. So it is lower in the cards. Okay.
Yeah, without you, what are the newer treatments of diabetic nephropathy, you know?
currently we are using this SGLT2 inhibitors and non-steroidal MRA.
ये डॉक्टर बताओ ना SGLT2 inhibitors
Yes, sir.
क्या helps, how does it help?
So SGLT2 inhibitor basically act at the PCT and act on the SGLT2 that basically absorb glucose and sodium. So on the blocking this, this will cause glycosuria. This will again there is decrease absorption of sodium, and this sodium basically goes to macular and they will typically feedback. So TGF causes the afferent arterial dilation and afferent arterial constriction, and there will decrease intraglomerular hypertension. Second, it also help to reduce the blood pressure because there is no increase basically the absorption of sodium, and good volume control because of glycosuria and diuresis. And also it helps because this PCT is exhaust with the loss of glucose absorption, so it again help to basically has anti-inflammatory and anti-fibrotic effect as SGLT2 inhibitor. Then non-steroidal MRA because it is thought that this patient has high aldosterone, and if this is not completely blocked by the ACE inhibitor ARBs, so it will help to again blocking the action of aldosterone. So that's why these help in.
How does it help then?
Yes, sir.
How does it help?
So this blocks the action of aldosterone. So there will
What is the effect? Beneficial effect?
both in decreasing the proteinuria and the hypertension.
What is its effect on interstitial fibrosis? Or
So
और
What
कोई
are the
drug?
things you should keep in mind while giving these newer drugs, SGLT2 inhibitor or Fendrinol?
So one thing is in the SGLT2 inhibitor, I will always look for there's always the high risk of this urinary tract infection. In the sick day, protocol if the patient is planned for surgery, then there's a we should stop, and there's a in diabetic foot again.
Risk of amputations
Yes,
or
sir.
and for Fendrinol?
For Finron, so there's a risk of hyperkalemia there. So if you are using as an add-on over the ACE inhibitor ARB, then we should keep check on.
So
तो
that
अभी
is very important.
GIP एडोनिस्ट बताया नहीं अभी
Yes,
आपने.
sir, GLP-1 locks. Basically, they have better cardiac effect apart from this kidney protection.
What are the various GLP agonists you know?
This liraglutide and semaglutide recently flow trial was on that. And
What is Mounjaro?
sorry, sir.
What is Mounjaro? सुना ही नहीं तूने? कौन भाई? टिर्ज़ापेटाइड नहीं सुना? हैं? What is the difference between semaglutide and tirzepatide? बताओ भाई. What is GLP agonist? What is GLP?
So this is
GIP.
glucagon-like peptide, basically. Glucagon-like peptide. 18.
और?
Sir.
कोई GIP भी होता है?
Yes, sir.
क्या? What is that?
GIP and
What is the difference between mechanism of action of tirzepatide as compared to semaglutide? Eh? Which one? It is a dual action. नहीं तुमने सुना नहीं मंजेरो? हैं? नहीं सुना? कैसे हो गया? और नहीं तो टीवी में अखबार में नहीं? आजकल तो इतना ज़्यादा
ट्रेंडिंग.
और कोई स्पारसेंटेन का क्या रोल है?
It's a dual endothelin receptor and blocker. So basically,
स्पारसेंटेन was tried at some time in diabetic nephropathy, पर अब नहीं है.
चलो और क्या इन्वेस्टिगेशन? हाउ विल यू इन्वेस्टिगेट दिस केस नाउ?
so I'd like to do the investigation.
तो क्या क्या इन्वेस्टिगेशंस करोगे?
Complete blood count, kidney function test, calcium, albumin. Complete blood count, KFT, kidney function test. Kidney function test is urea 19, creatine 0.9, sodium 136, potassium 4.7, calcium is 8.9, albumin is 2.6, globulin is 3.
Globulin is 3. Total protein?
5.6.
5.6. Okay.
Liver function is normal, sir, and HbA1c is 6.2. Viral markers are negative. Urine albumin creatine ratio is 6.2 gram, and the UPCI is 9.2 gram. Serum plasma was negative, and serum free light chain assay and serum protein electrophoresis was negative. Biopsy.
So with these investigations, so he has nephrotic range proteinuria with hypoalbuminemia with lipid profile नहीं बताई तुमने?
So state was not done.
It was not done. आप nephrotic syndrome बना रहे हो?
कैसे हो सकता है?
लिपिड प्रोफाइल तो करवाओगे?
Yes, sir.
कि क्या मिलता है लिपिड प्रोफाइल में?
Lipid profile, there will be hypertriglyceridemia.
हाइपर
high LDL,
सबसे पहले हाई
high
कोलेस्ट्रॉल,
cholesterol, LDL cholesterol.
एलडीएल बाद में आएगा, पहले हाई
High
कोलेस्ट्रॉल,
cholesterol,
हाई
total cholesterol.
ट्राइग्लिसराइड्स,
Yes, sir.
कितना ज़्यादा होता है? व्हाट इज़ द हाई लेवल, मतलब कि व्हाट इज़ द नॉर्मल कोलेस्ट्रॉल एंड हाउ हाई इट शुड बी?
It's around more than 300 to 100.
What is the normal cholesterol level?
So less than 200.
Yes. So what is hypercholesterolemia? More than 250. Okay. So why the cholesterol rises in nephrotic syndrome?
Because of there's a loss of lipoprotein and hepatic lipases. There's a LCAT, there's a loss of LCAT. So these basically loss of albumin cause increase this lipoprotein, and there's a basically abnormal this
Because of the low albumin, there is low oncotic pressure, so liver tries to compensate and increase the production of the proteins, lipoproteins. So that is the reason cholesterol also rises in patient of nephrotic syndrome. So you should do for the completion of the definition of the nephrotic syndrome, though it is nephrotic range proteinuria with hypoalbuminemia with edema, but supportive is always high cholesterol and triglycerides and lipiduria maybe. Okay. So you said PLAR was negative.
Yes, sir.
So why you have checked it?
Because I basically kept the membranous as a first differential, so I'd like to keep the blood as a primary membranous.
So PLAR is negative, so membranous is ruled out.
No, sir. So it is positive in a primary membranous nephropathy. It is positive in around 70 to 80% cases, and 20 to 30% cases can be negative.
Okay. What other antigens can be positive in membranous?
Other antigen are thromboxane 7A, NAL1, there's a FAT1, SIMA4B, agistocin 1, and CAM.
Okay. So serum protein electrophoresis is also negative.
Yes, sir.
So you have evaluated further also light chain assay or something like
Yes,
that?
sir. Free light chain assay and serum protein electrophoresis both were negative.
Negative. So your all the differential diagnosis, primary and systemic amyloid or myeloma are negative by the. So now what else?
I'd like to go for the kidney biopsy.
Kidney biopsy. Okay.
So in the kidney biopsy, in the LM there were two core with 23 glomes, one globally screws. In the glomerular compartment there was a diffuse uniform membrane thickening with mild mesangial expansion with normal cellularity, no endo or extracapillary proliferation. In the tubular interstitial compartment there was no tubular atrophy or interstitial fibrosis, and vascular compartment was normal. In the immunofluorescence, IgG G4 was 3 plus granular along the capillary loop. IgG1, G2, G3 was negative. IgM C3, C1Q was negative, and kappa lambda both, so 3 plus along capillary, and there was no restriction. In the immunohistochemistry, the PLAR2 was positive.
So how come?
Sir, in the initial phase of disease, this or very low titer, there can be possibility the serum antiplatelet antibody is negative, but there can be staining in the biopsy.
Any other thrombospondin or NEL1, anything they were done or not done?
No, sir, it was.
Why? For the completion sake, these are done
Hello.
these days. Okay. Then electron microscopy.
It was awaited, sir.
It was very good. So your diagnosis.
It's membranous nephropathy, primary membranous nephropathy.
So what is the pathogenesis? How does?
So this PLAR2 basically act as an intrinsic antigen, and there's a basically antibodies to this PLAR basically cause local complement activation, and because this belongs to the mannose binding family, so more of lectin pathway is more activated along with the alternate pathway.
Yeah. Okay.
So this basically cause the local activation causes the basically damage at the podocyte level. There is a protein leakage, and subepithelial deposits will be there in this case.
So in the EM, what are you expecting?
In the EM, there will be some spike-like pattern in the subepithelial region.
The spike-like pattern is seen in the light microscopy. In the EM, what is the hallmark?
Thickening of the G-beam.
So any special stain you use to see the spikes and the basement membrane thickening in light microscopy?
Silver we use to look for the G-beam, and PAS can again be used.
So in EM you will see the deposits,
Yes, sir.
subepithelial deposits. Okay, so there is a grading 1, 2, 3, 4 depending upon the how much spikes are there, or then they are embedded in that or not. That is histological classification from grade 1 to grade 4 of the membranous. Okay. So now you have the diagnosis of membranous and you have proteinuria of you said 6 grams.
Yes, sir.
So how will you manage this patient?
So
With normal renal functions,
yes, sir.
GFR is okay, creatinine is okay, and hypoalbuminemia is there, and he has a proteinuria of 6 grams around. So how will you manage?
So we'll start with this ACE inhibitor ARBs. We will follow if there's a basically almost 20 to 30% case can go to spontaneous remission. So we'll maximize the treatment antiproteinuric drug, and we'll follow.
So ACRBs for how many months you will see whether patient is going into remission or not?
At 3 to 6 months we follow these patients.
6 months.
6 months.
Yeah. So you do the proteinuria every month to see whether proteinuria is decreasing or not. So one is ACRB, other?
The patient is not responding to this treatment, then we can go for the immunosuppression in this case. So in the immunosuppression,
Not responding means like it is like what are the definitions of remission, partial remission, non-response to the treatment?
for the remission, basically there's a on the follow-up there's a basically proteinuria less than nephrotic to some nephrotic proteinuria, because proteinuria can persist for a longer period even there's immunological clearance. If we follow this patient with the PLAR, and if the PLAR is negative, then proteinuria can persist for a longer time.
So in nephrotic syndrome, remission is always like on proteinuria.
Yes, sir.
It is not on PLAR.
Yes, sir. So in the nephrotic syndrome, the proteinuria less than 300 mg per day, and or partial remission, there is a more than 50% decrease from the baseline proteinuria decrease. So that will be counted as a partial remission.
And no response?
No response is basically persistent proteinuria more than 3.5 gram basically.
So you are following this patient and his proteinuria has become from 6 grams to 12 grams in next 3 months. So what will you do?
We'll go for immunosuppression, sir.
What immunosuppression?
In this case, we can go for the rituximab or the ponticellin regime.
What you will give? You are the treating physician. No?
Yes, sir.
Patient is not going to decide. You will have to decide. You will have to tell him pros and cons.
So we can go for the rituximab in this case, and
Why not Ponticelli? What is Ponticelli and what is modified Ponticelli?
so initially in the ponticellin we used to give the chlorambucil at that time, but now we use the cyclophosphamide and steroid.
So what is the regime says? How will you do it?
Yes, sir. So in the regime we give the methylprednisolone on the 1, 3 and 5 month of 3 days initially, and then prednisolone 0.5 mg per kg per day, and in the alternate month we give cyclophosphamide at 2.5 mg per kg per day.
So what are the remission rates with the Ponticelli and with the rituximab?
The remission rate are higher with the Ponticelli regime. In the recently recycled trial, it's around 75 to 80%. The remission rate are better with the Ponticelli. With the rituximab, it's around 60-65%.
So why are you not giving him best regime? Why you want to give him rituximab? Is there any fear in your mind in giving Ponticelli? What are the side effects of cyclophosphamide basically?
Basically, immunosuppression.
Steroids and cyclophosphamide, the risk of?
Immunosuppression is very high.
So what
and
are the risks? Infections
Infection, yes, sir.
and malignancies with cyclophosphamide. What kind of malignancy and what dose?
More than 36, cumulative dose of more than 36, there's a definite risk of malignancy.
36 what?
36 gram.
Okay. What kind of malignancies?
Solid organ malignancy is very common with the.
Or?
And this ALL, so leukemias.
Okay, so there is a risk of skin cancers,
Skin cancer.
okay, and solid organ cancers in the long term. And risk of in the short term there is a risk of infections, more of fungal infections and viral infections.
So considering his basically is already diabetic, so the risk of infection is already high.
And what are the risks associated with rituximab?
Sorry, sir.
Risk associated with rituximab.
With the rituximab, the risk of basically fear of tuberculosis is high. Infection risks are high, but not as much as cyclophosphamide.
What other monoclonal antibodies are there for membranous newer therapies?
Belimumab and obinutuzumab.
Are they available in India?
Obinutuzumab, yes, available, but belimumab not available.
अभी नहीं बस ठीक
Chalo.
क्या what is your name
Sir, Dr. Ashish,
which hospital
Medanta.
चलो good
Thank you, sir.
ठीक
Thank you.
बड़ा था रेजिडेंस
मेरा रोहिणी है सर।
अच्छा बड़ा ट्रैफिक था यार तुम तो काफ़ी जल्दी कर पड़े हैं
नहीं मैं तो सिर्फ जॉब पे से